So a little bit about Dr. Alex Chan. I'm lucky to have him as a colleague. He graduated from the Manitoba School of Medicine in 1991, and he went on to do an internal medicine residency here at UBC, followed by a general internal medicine fellowship. He then went to the University of San Francisco in the VA system and did training in addictions, as well as the Center for Addiction and Mental Health in the University of Toronto. He also did his master's in public health at Harvard University. So currently he works at the Hospital Addictions Consult Service at St. Paul's Hospital, as well as at the Providence Crosstown Clinic. And he also attends on the General Internal Medicine Clinical Teaching Unit. So with that introduction, I'd like to give a warm round of applause to Dr. Chan.
Thank you, Anita. I'm really impressed by the turnout, despite the cold and the fact that tonight is the first episode of American Idol, so I'm sure the expectations are very high. I'm sure each presenter who's been here in the past has thought that their topic was the most interesting and could go on for hours and hours and hours talking about their area of interest. And I'm no exception to this, but I promise I won't talk for hours and hours. I've got enough to talk about here. I could go on for hours, but we'll definitely be mindful of the time. Here are some things that I will be talking about, but again, based on time, we may not be able to get to all of them. This is an overview. We're going to talk about what is a drug addiction. There's a lot of different terminology and it can get confusing. How and why do addictions occur? What kinds of drugs are abused? What is the worst drug addiction? People always ask me that all the time. How are drug addictions treated? Why are addictions difficult to treat? And what is the future of addiction treatment? So first off, what is a drug addiction? This is a comic book from around 1970, highlighting at that time a controversial topic, which was drug abuse and addiction. Certainly, over the years, it's become more mainstream in the media, as well as in our media. We read a lot about it more often, and so we're a little bit more familiar talking about it. So when we see a topic like drug addiction, it's no longer shocking like this comic book cover would have been in 1970. So looking at a definition of addiction, to really simplify what we're talking about when we talk about addiction, we can consider it to be a persistent pattern, or i.e. a habit, of use of a psychoactive substance, which could be a drug or alcohol, for example, that occurs despite negative consequences. So it's the continued use despite negative consequences, okay? That's the key. Now, when we look at use of potentially addictive medications, we can look at a spectrum of use. So it's not just if you don't use, you're not an addict, but if you use, you are an addict. So it's not all or none. There's a lot of in between, right? So someone could be abstinent, meaning that they don't use the drug at all, or they could be low-risk users. So for example, people that have experimental use of the substance. They could be high-risk users, either by using large amounts for short periods of time or for longer periods of time. And then finally to abuse and dependence. Abuse and dependence are the medical terminology, and those would be the main things that fall under the umbrella of what the lay public would understand as being an addiction, okay? On the one hand, drug use can be voluntary, but as it becomes an addiction, it in a sense becomes involuntary, which is why it's hard to just say no, okay? It's more than just saying no. So again, on the one hand, you can be a non-user, you could become an episodic user or a regular user. When we look at alcohol as an example, again, there are plenty of people that drink alcohol who are not addicted to alcohol. So it's not an all or nothing phenomenon. You could be a non-drinker like myself. You may be someone who drinks socially, as we call it, right, Dr. Talapu? And some people are daily drinkers, but can be daily drinkers without actually having an addiction. And then there are other people that can have an addiction, meaning that they continue to drink despite having lots of problems as a result of their drinking. and that could be episodic drinkers or they could be regular daily drinkers. Again, using alcohol as an example, a standard drink is considered one standard can of beer, for example, or one standard glass of wine, or one standard shot of hard liquor, okay? And when we look at what are considered to be the recommended quote-unquote safe drinking limits, you can do your own inventory here. For men under the age of 65, safe drinking limits is considered to be no more than 4 drinks in a single day, and no more than 14 drinks over a 7-day period. For women and for men over the age of 65, it's no more than 3 drinks in a day and no more than 7 drinks per week. Now, that doesn't mean that if you're over the safe drinking limits that you're an alcoholic. It's just that if you're over, your risk increases. So let's look at that. So this is based on data from the United States, for example. So for people that never exceed either of those limits, so the daily limit or the weekly limit, and that's 72% of the population, people that do not exceed the limit, the risk of having a problem with drinking, i.e. an addiction to it, is less than 1 in 100. Now, if you exceed the daily limit but not the weekly limit, and that's about 16% of the population, your risk of an addiction goes up to 1 in 5 or 20%. And if you exceed both the daily limit as well as the weekly limit, and that's 10% of the population roughly, your chances are 1 in 2 or 50%. So you can see how dramatically that risk rises. Now, how and why do addictions occur? So why do I have this picture here? So we have to think about what is it about our brain that allows us to become addicted, and why do we have that part in our brain? What's it for? And the answer is, think back to prehistoric days, or even before prehistoric days. It was really important for us as people to survive. And so we had to have built-in mechanisms that would drive us to these survival features. And one of the survival features is sex, because if no sex, you can't repopulate. And the other is food. So as you can see, Fred Flintstone is thinking about both of them in this picture. Okay? So these are very basic drives that probably originate in what we would call the oldest parts of the brain developmentally, kind of like the lizard brain, okay, the automatic things. And where it says VTA and nucleus accumbens, these are fancy medical names, but these are the areas where the reward pathways for the brain is. This is where the circuitry is that motivates us to do things that are pleasurable, and therefore, because they're pleasurable, we want to do them again. So that's why we get pleasure out of sex, we get pleasure out of food, as an example, okay? Now, this next picture is a very complicated picture that is even complicated for physicians. The only reason for bringing this up is that this is a diagram, and what it shows is that in the pleasure center of the brain, different drugs of abuse act on different receptors in the brain, but they all have one thing in common. They all, in some way, increase the levels of dopamine, a chemical in the brain, and this is associated with the feeling of pleasure, okay? So let's look at some predictors of addiction, because this will tell us a little bit more about how people become addicted and why they become addicted. So we can kind of look at predictors of addiction in sort of 3 different domains. One is the substance or the drug itself. What is it about the drug that makes it addictive? Number 2, we can look at the environment that the person is surrounded by. And number 3, we can look at the individual person themselves. So as far as the actual substance or drug, if the substance is more available, more likely that more people will be addicted to it. So availability is a very important feature. In the modern world, transportation is ubiquitous. So availability of anything from anywhere around the planet is easy to acquire now, whereas in the old days, before they had airplanes and before they even had ships, different regions would have different experiences with addiction based on what was available locally. But now pretty much everything, especially in a big city, is available locally. Number two, how much does the drug or substance cost? We know from our experiences with tobacco in Canada, for example, that when the Canadian government raised the taxes high enough, the smoking rates diminished, particularly for young people. I know my own father at the time, who at that point had been a smoker for 40 to 50 years, with us kids, including his son who's a doctor, always telling him to stop smoking. He never did until one day the government raised the price of cigarettes enough that he said, that's it, I've had enough. So cost makes a big difference. Number three, speed of entry to the brain. If the chemical gets in, the faster the chemical gets into the brain, the more addictive it is, okay? And so that has to do with the chemical properties of the drug itself and how the drug is administered, which is why, for example, intravenous or injection of some of these addictive substances occurs, okay? Because you get it into the brain faster, you get bigger bang for your buck, so to speak. Number four, what are the features of that specific drug or chemical? What effect does it actually have on the brain? Okay, some people like to feel really speeded up and high. Other people prefer to be more mellow. So if I'm a mellow kind of guy, I'm going to choose a drug which makes me more mellow, for example. Okay, now let's look at the environment. We know that drug addiction is more prevalent in people of low socioeconomic status. We know that there's a relationship between drug use also and poor quality of parent-child relationships, parental conflict, and parental and sibling drug use. So what goes on in the home can be an important factor in whether someone goes on to an addiction. Number three, and associating with antisocial and drug-using peers. So the company that you keep makes a difference. Number four, social stability or instability. So when times are very chaotic, like during the Great Depression of the 30s, or maybe the recession / maybe depression of our modern era, addiction rates go up. And number five, trauma. One of our most recent experience. Trauma can be personal trauma, but it can also be group or societal trauma. Like, for example, when the World Trade Center was hit by the terrorists 10 years ago, a creative scientists studied the rates of consumption of alcohol and drugs before the World Trade Center hit. They looked at that information, and then they kind of looked at what happened afterwards. And they found that substance use increased dramatically after 9/11 in the New York area, for example. There was also greater rates of psychiatric symptoms as well, like depression, for example. So the environment is a very important factor. And then there are individual factors as well, like, for example, genetics. Let's look at alcohol, for example. Does anyone in the audience, turn beet red when they drink any alcohol? I know I do. Does anybody else? Okay. What that is, it's actually due to a genetic defect, okay? And for people like myself who have this genetic defect, which is actually common in the Asian community, when we drink alcohol, our body doesn't break it down properly. So toxic levels of a byproduct of alcohol build up in our bodies and make us feel sick, okay? So that's a genetic predisposition, not to acquiring an addiction, but a genetic predisposition to avoiding an addiction. That being said, genetics is not everything. My cousin, for example, he gets the exact same flush reaction and itchiness that I get, but he drinks tons. So he drinks for the whole family. So you can overcome genetics in some ways. Okay. Number two, as far as individual characteristics, people that have an innate sensation-seeking personality, so thrill seekers, people that like to get a rush out of things, okay? Like people that are into extreme sports or whatever it might be, fast cars, for example. Number three, conduct disorder. So especially at a young age. So for adolescents who get into trouble with the law, sometimes that's a reflection of drug use that's ongoing. But even for those who don't have a history of drug use yet, if they are involved in those kind of behaviors, it increases their risk of developing addictions later on. Number four, psychiatric conditions. We know there's a lot of overlap between people that have addictions and people that have psychiatric problems like depression, bipolar, schizophrenia. There's a real overlap. So if someone has a psychiatric disorder, their risk of developing an addiction is much higher. Also, people that have an addiction are at much greater risk of developing psychiatric problems as well. So there's a link there. Poor school performance is also predictive of developing addictions later in life. Use of tobacco or alcohol early in adolescence, also a predictor. Earlier onset of illicit drug use or illegal drugs, also a predictor. Let's look at this. Who's at greater risk of developing a problem with alcohol? So we're going to look at two teenagers, and basically their previous experience with alcohol has been the same. So this is not, oh, well, one person has already had a lot of alcohol before and the other hasn't. So this is looking at two people who have had the same amount of alcohol history in the past, teenagers. So teenager A can drink 5 beers before he gets wasted or drunk or intoxicated. Teen B gets tipsy after drinking 1 beer only. So one person can handle his liquor and the other cannot. Okay. So who would guess by raising your hand that teen A is at greater risk of developing alcoholism? Okay. And raise your hand, teen B. So the science research from this is actually that teen B is at greater risk of developing alcohol problems like alcoholism. Again, when you're talking about later in life, after people have a lot of history of alcohol consumption, the more alcohol that you drink, you can build up tolerance, okay? So we're talking about a different scenario here. This scenario is in young people before they've actually had that history and built up the tolerance. So the study that was done to show this took into account tolerance. So they matched up people of different, of equal tolerances or controlled for tolerance. So that's not the issue here. This is purely predictive in the future, okay? So teen B, if teen B wants to drink more, really has to work at it, right? But for whatever reason, it seems kind of illogical. They're at greater risk. And the ability to handle alcohol innately is a genetic predisposition. Oh, I see someone raising their hand, but again, we're not going to stop for questions because we're recording, but we will have lots of time for questions later. Now, what kind of substances are abused? Tobacco is something that we're all familiar with. Sedatives is another family of addictive substances, and they include alcohol, opioids or pain medications, benzodiazepines and barbiturates. They're often used for sleep or for seizures, for example. Stimulants, cocaine, amphetamine are typical examples. Hallucinogens like marijuana, LSD, magic mushrooms, for example. So we're going to look at some of these individual drugs. We're not going to look at all of them. Okay. Number one, opioids. There are different terminologies, including opioids, opiate, and narcotic. And it's very confusing even for doctors to know what this actually means, okay? An opiate is a naturally occurring drug, such as morphine or codeine, which is derived from the opium plant or poppy. Opioid refers to all morphine-like substances which can be natural, meaning coming directly from the opioid plant, semi-synthetic, meaning you take the contents from the natural opioid plant and you change them chemically, or completely synthetic, meaning made from scratch, doesn't come from opium, doesn't come from the products of opium. Okay? Narcotic, from a medical point of view, refers to morphine-like substances, but from a legal terms means anything which is a controlled substance. So, for example, you may read in the newspaper about narcotics from a legal point of view, and what they're referring to is use of any illegal substance. When doctors talk about narcotics, they're primarily talking about these pain medications that come from the opium plant or have a similar chemical effect in the brain. And that's a nice, beautiful picture of lovely poppies. Who would have thought that these things would cause so much trouble for people? But they also create a lot of good as well, right? Because this is where we get a lot of our very powerful pain medications from. So basically, the poppies that lead to opium production, as far as the illegal drug trade is concerned, most of it actually comes from the Afghanistan region, about 90%. For the opium that we give to the pharmaceutical companies to make into medications that we as doctors prescribe and we as patients use, the majority of that does come from India, but they do also grow it in areas of South America, even Australia, as strange as that sounds. So basically what happens is the poppy plant grows and thrives, flowers, the flowers fall off, and you're left with this opium poppy pod. What people have to do to extract the opium is you have to manually scar the outside by putting these little nicks into the skin, and then the syrup or sap leaks out of it, okay? The next day you come back and that syrup has dried out, and you have to manually scrape it all off to collect it, okay? So this is a very laborious process. Once you scrape it all off, you're left with raw opium, which looks like this black tarry substance, okay? In the old days, this would be smoked directly, okay? But in the modern era, especially in North America, we don't see a lot of direct opium use. Interestingly enough, I do talk to some patients who do still directly use opium, and the ones that I've met have been immigrants from Iran. For people that live closer to the source, it's a lot easier to get opium than to get heroin, which we'll talk about in a minute. So if you're closer to the source of the original product, you're probably going to use the original product, okay? Now, heroin is related to opium. It's got different names on the street. Locally here in Vancouver, it's mostly known as down. Back in the 60s and 70s, people used to call it H or horse. There are different names for it. And basically what happens is if you take your raw opium and you extract from that morphine, if you combine it with another chemical, then you create heroin. And heroin was first created in 1874, so it's been around for a long period of time. And has various sort of colors to it and textures to it, but generally heroin is found as a powder form. There are different ways of using it. Injecting it, which means going right into the vein with a needle and putting it right into the bloodstream. It can be injected into the muscle, and that's called muscling. It can be injected into the skin tissue, and that's called skin popping. It can be smoked, and in some circumstances, that's called chasing the dragon. It can also be snorted, and it can also be orally ingested or eaten. So there are a lot of different ways of using it. The biggest bang for the buck is injecting it, okay? And that's the paraphernalia that we would see for injecting. And injecting can happen in all sorts of places in the body, in the arms, the legs, the hands and feet. Sometimes people will inject into the neck when they've run out of veins in other areas. For people that don't want other people to know that they're injecting, there are sometimes hidden areas where people inject as well, like under the armpit, under the breasts, or on the veins on the breasts, sometimes deep in the groin. So there are a lot of hidden areas. So as a doctor, even if I don't see what we call track marks, which are these little dot-like spots on the skin, doesn't mean a person is not injecting. So when I see my patient, I'll ask them to show me where it is they inject, and sometimes I don't really see much of anything. Sometimes I see a lot, okay? Now, prescription opioids, basically same family of medication, but these are obtained legally or illegally, but manufactured by pharmaceutical companies, okay? And we as doctors and patients use these in terms of pain medications, okay? Now, prescription opioids are actually the fastest growing drug abuse problem in North America. So although we always see in the media and hear reports about heroin, the prescription opioids is probably a much bigger problem, okay? And as I was saying, it's a growing problem. So if you look at the top line there, that's prescription opioid deaths in the United States over the last 10 years. The blue line is cocaine, and the green line there is heroin. So there are a lot more prescription opioid deaths than heroin deaths, okay? But certainly the heroin gets a lot more media attention. Next, let's talk a little bit about cocaine. Cocaine is a stimulant, and again, it's got lots of different nicknames as well on the street. There are kind of two forms of cocaine. For those of you who've done chemistry, think about an acidic form of cocaine and a basic form of cocaine. And that's important because it determines how it's used, okay? So the acidic form of cocaine is what we commonly know as cocaine powder. And that's the kind of cocaine that people snort, okay? Or that people inject. Cocaine base is cocaine that is smoked, okay? Cocaine comes from this beautiful looking plant, okay? Which is a coca plant, which is found most commonly in Colombia. And the cocaine is within the leaves, okay? The cocaine was first extracted from these leaves back in the 1860s. And as I was saying, there are beautiful fields of coca plants that produce cocaine in South America. And so how do we get cocaine from this? The leaves are collected from the plant itself, and then the leaves are broken up, and then they're put into a chemical, and they're mashed, almost like grapes, making wine, right? So you mash up the leaves to extract the cocaine, and eventually you're left with pure cocaine, which is transported or smuggled into the country in blocks and is sold on the streets in powder form, okay? And as I was saying, there are different ways that cocaine can be used. Traditionally, closer to the source, cocaine is still used by chewing the leaves, okay? You get a much lower amount of cocaine, less effect on the body, and this is commonly used for people that are climbing up the mountains and need extra energy. So it gives them that enough boost to sort of get up that mountain, okay? For people that are addicted, that's not good enough. With addictions, you tend to end up needing more of a drug to try and get the same high that you used to get. So you're always using more and more and more. And so eventually that means the leaves themselves are not enough. And certainly in North America, we don't really see people chewing cocaine leaves because they want the good stuff. And so in this case, again, it's either snorted or injected, or it's smoked. So this is a picture of Richard Pryor. For those of you who are maybe a little bit older, maybe remember Richard Pryor was a famous comedian. And one of the things that happened to Richard Pryor, unfortunately, is that he suffered severe third-degree burns from freebasing cocaine, okay? And what freebasing cocaine means is you take your cocaine powder, you add some chemicals to it to change it from an acid to a base so that it can be smoked, okay? Because smoking it gives you a bigger bang for your buck than snorting it. Now, unfortunately, that process can be dangerous because you're using a lot of flammable material, and unfortunately the material caught on fire, and he caught on fire. Now, the cocaine that is smoked nowadays is usually not freebase cocaine. The chemical recipe is a little bit different. So rather than ending up with freebase cocaine, you get cocaine rock. And cocaine rock is also smokable, but it's got a lot of impurities from it. From freebasing cocaine, you would use chemicals to get rid of the impurities so that you would have a more pure cocaine that you could smoke. But again, those chemicals were flammable. The modern smoker of cocaine smokes rock cocaine. Because it still has all those impurities in it, it's cheaper. And this is what really sparked widespread use of cocaine in the 80s and 90s. Prior to development of rock cocaine or crack cocaine, cocaine was considered to be a relatively expensive drug that was used by well-off people, businessmen, professionals, etc., lawyers, doctors, etc. But in the 80s, when crack cocaine became available, that actually became a drug of the poor because it's very cheap. And that's why we saw an explosion in use of cocaine in inner cities and amongst the poor. Next class of medications, amphetamines, still in the stimulant family, but slightly different than cocaine, comes in a couple of forms: illegal forms that are homemade or home cooked, or prescription medications that are abused and diverted. So I'm just going to go on from there. This is what crystal methamphetamine looks like, also called ice. And as you can see, it's kind of self-explanatory why it's known as ice. This is an example of ecstasy pills. Ecstasy is derived or created through a process of changing the chemical structure of a stimulant and then making it into what's called ecstasy. So it comes from the family of stimulants, although its properties are a little bit different than your other stimulants. Rather than it making you really, really high, it makes you feel really, really warm. So some people will call this drug empathy as a nickname rather than ecstasy. Okay. And the amphetamines can be smoked or snorted or injected, lots of ways of using it. Probably the illegal drug that we have the most knowledge about is marijuana, as far as it being used widespread, particularly in North America. And it's arrived from the marijuana plant, or Cannabis sativa. The active ingredient is THC, although marijuana smoke actually has hundreds of different chemical compounds in it. And there are different forms of marijuana. Hashish oil, which is got the highest concentration of THC, all the way down to marijuana leaves themselves, which have the lowest concentration. But we do know that over the last 20, 30 years, the THC content has gone much higher over the years as people genetically engineer the marijuana to maximize the high from marijuana. And so the marijuana used now is a lot stronger or more potent than it was back in the 60s. Okay? And this is just to demonstrate that not all joints are created equal. For alcohol, we have standard sizes that we can ask patients about. For marijuana, it's a little bit more difficult because there is no typical standard size. So someone may say they smoke only one joint a day, but that's a little bit different than a little small joint. Marijuana is also available to doctors, as far as the THC is available to doctors in pharmaceutical medications as well. There's a lot of controversy about the medical uses of marijuana, but has been proposed for use in pain, nausea and vomiting, to stimulate appetite, to treat muscle spasms, to treat seizures. There's a lot of controversy about the use of medical marijuana. I could spend a whole hour just talking about medical marijuana, and I do with the medical students, but I'm not going to do that right now. So next, a question that's asked of me a lot: what is the worst drug addiction out there? What one drug should I avoid if possible? And that's a little bit of a difficult question to answer because you can look at it from different angles and get different opinions. So for example, these are some different ways that you could look at this question. Number one, which drug is most widely used? That might be an indicator of what the worst drug is. Number two, which drug causes the most harm? Number three, which drug is the most addictive? And number four, which drugs have specific medical treatments. Okay? So if you get addicted to something where there isn't a medical treatment, then maybe that's the worst drug. Okay, so first let's look at which drug is the most widely used. This is data from a paper that was published really recently, just within the last few months. And this looks at global use of drugs or substances. And this is through the World Health Organization. And what this shows that marijuana use, as far as the whole entire world is concerned, between 124 and 202 million people smoke marijuana, or up to 4.5% of the global population. As you can see, beside there, under North America, a lot more marijuana is used in North America, 10.7% of the population. So a disproportionate amount of marijuana use in North America. When we look at opioids, about 0.3 to 0.5% of the global population uses illicit opioids, and that number is relatively similar in North America, up to 0.5%. Amphetamines, 1.3% versus North America, 1.1%, so very similar. And then cocaine, 0.5% over the world, North America, 1.9%. We do know that the richest countries tend to have the highest overall drug use, and a lot of that goes back to availability and cost. Let's look at what happens in Canada. The numbers are very similar. Again, marijuana, about 10%. Compare that to alcohol, which is a legal drug, 77%. Okay. Again, looking at the other illicit drugs, really small percentage of people that we're talking about, okay? But yet a very big impact. Which drug causes the most harm? Again, looking at global information, estimates as follows. As far as illicit drugs are concerned, are felt to account for about 0.4% of deaths around the world, whereas alcohol accounts for or causes 3.8% of deaths across the world, and tobacco 8.75%. Okay, so from this point of view, tobacco might be considered the worst addiction. This is sort of similar information in a different form. Again, tobacco causes the most deaths. What this does show, though, is that when you look at alcohol and drugs, causes more deaths at a younger age. Therefore, the younger you are when you die, the more years lost. Okay? But even when you look at total years lost, tobacco well exceeds alcohol and drugs. Same is true for females, but to a lower extent. The two graphs look the same, but the scale is a little bit different. Okay, so for women, it's about a half to a third of the deaths of men. Okay, that's pretty similar. Okay, when we look at individual families of illegal drugs, so opioids like heroin, cocaine, amphetamines, and marijuana, what these numbers represent is that if you compare a group of people that don't use any of these substances and compare them to, let's say, cannabis, that one number means that there's no increased amount of deaths from the use of marijuana. Okay, so for people that don't use any drugs, the death rate would be 1, for example. So cannabis equal rates of deaths. However, this number may be an underestimate of the true number because it doesn't really take into account motor vehicle deaths, for example. As far as amphetamines or speed, if someone uses amphetamines or speed, their risk of death is 6 times greater than someone who doesn't. And then when you look at opioids, for someone who's addicted to heroin, for example, they have a 14 to 15 times greater risk of death than someone who isn't addicted to that. Another indication might be, well, how addictive is a substance? So for example, what is my risk of actually developing an addiction to something that I try? Okay. So true or false, has anyone ever heard that Coca-Cola used to contain cocaine. So for those of you who think that's true, raise your hand. For those of you who think that's a bold-faced marketing lie, raise your hand. So the answer is actually true. It had a very small amount of cocaine in it in the 1800s. And right around the turn of the century is when they stopped using it, okay? Stopped putting it in the Coca-Cola. So when they say it's the real thing, it actually really isn't the real thing compared to what it used to be. As you can see, it used to be marketed as an ideal brain tonic and is used specifically for headaches. So I'm sure it will do something to your headache. So again, getting to the question of which is the most addictive medication. So when we look at alcohol, if we were to take 100 people who've had alcohol at least once, and then follow them later in life, look at the 100 again, 15 of them at some point will develop an addiction problem. So 15 out of 100. If we look at tobacco, almost 32 out of 100. If we look at marijuana, 9 out of 100. Cocaine, almost 17 out of 100. And heroin, 23 out of 100. So, this goes to the question of experimentation, right? Because experimenting means I try a drug, maybe use it for a while, but it never goes on to becoming an addiction. So for an experimenter, you don't want to experiment with tobacco because your chances of becoming addicted to it are much higher, okay? If you were to try and experiment with marijuana, you have a much lower risk of actually becoming addicted to it. So we're at about 40 minutes there. So no, what I'll say is, okay. Well, this will be my wrap up then, because strategies to deal with the consequences of drug use. We've heard of what they call the 4 pillars approach, has been talked about locally here, and these are sort of 4 ways that dealing with the problems of drugs. Okay, and these are the general strategies that are used to reduce the harms of drug addiction. Number 1 is prevalence reduction, which just means reducing the demand. So reducing the number of people that want to use drugs, okay? And the interventions that have been used or tried over the years have been prevention, like, for example, education programs amongst children, or it could also mean specific treatment of people that are already addicted. Next is quantity reduction, which has probably had the most amount of money put into it of all of these mechanisms. Quantity reduction means trying to reduce the amount of drugs that are available to people. So during the Prohibition era, they tried to make alcohol illegal, again, to reduce access. Nowadays, for example, there are different programs like drug eradication problems, so going to the source, like Colombia, to try and exterminate all the cocaine plants, for example, or trying to prevent smuggling, or putting smugglers in jail, or putting people that use drugs in jail, have all been tried to tackle this problem. And then harm reduction. Harm reduction means trying to reduce the harmful consequences of the drug use when the drug use occurs, but the specific aim is not necessarily to stop the drug use per se. What that means is accepting that if someone does use a drug, how can we reduce the harm that comes from it? So maybe I'll wrap up there.